Here we are presenting various technical difficulties in internal limiting membrane peeling. ILM is produced by retinal Muller glial cells. It represents the structural boundary between the retina and the posterior vitreous. It has smooth vitreal surface and irregular retinal surface. As we know, macular hole is produced due to antero-posterior traction and tangential traction theory. Indications of ILM peel includes all types of macular hole, epiretinal membranes, vitreomacular traction and diabetic TRD. First, get practice of ILM peel in demo eye to get the feelings of ILM peel. After doing posterior vitreous detachment and core vitrectomy, we shall remove all structures lying above ILM meticulously and completely. Then Adakite brilliant blue dye has to be injected to stain the ILM. First pinch is always difficult to start. It can be initiated along the vascular arcades, along the disc margin and temporal to macula. Ideally, ILM peel shall be initiated with central macular lens. And with wide field lens, area of working fundus is increasing with compromise on. It looks difficult to do ILM peel in diabetic macular edema case as retina is more swollen. But simultaneously ILM thickness nearly become around 4.5 micron, making DME ILM peel little easy. For the beginner to start ILM peel, Finese loop is the safest tool to get the edge of ILM, and later it can grasp with ILM forceps. We used PVA sponge to elevate the edge of ILM like diamond dusted forceps used to do that. First time we fail, and later we could do it without any complications in many cases. As in this case, we can easily get the ILM edge by rubbing PVA sponge softly over the retina without undue pressure. PFCL will work as second hand to stabilize the retina for initiating ILM peel in detached retina. PFCL makes our job easy to peel the ILM more safely in retinal detachment. It is even possible to peel the ILM in detached retina. But most of the time it will come as piecemeal manner. Sometime we can get peeling like circular maculorhexis even in retinal detachment cases. 10,000 cutting beveled tip vitrectomy cutter can be safely used to grasp and elevate the ILM flap. Vacuum mode of cutter can do it, as we also tried in our few cases. For this linear mode of vacuum to be used cautiously to avoid grasping whole retina in cutter opening port. There is a chance of retinal incarceration and microretinal tear if we do in detached retina, as it happened in our initial cases. This happened because of sudden undue pressing on foot switch while working very close to retina. Later ILM peel is completed with the ILM forceps. Multiple radial inverted flaps in ILM peel has made macular hole surgery really a vision gain surgery in nearly 90% of cases. Most of the time this multiple inverted flap technique had been seen closing very large macular holes too. Multiple retinal hemorrhages are seen more commonly in inverted flap technique, as we have to pinch the ILM at each time to new place for getting ideal inverted ILM flap. Broad base ILM flap technique also work very well in large macular cases. But many times it is difficult to trim the ILM flap without detaching it from the retinal surface. We have to be very careful while doing trimming of the internal limiting membrane flap with the vitrectomy cutter. There is a high chance of internal limiting membrane flap can be eaten up by the cutter and we will lose the whole internal limiting membrane flap. I was lucky to save the ILM flap while doing fluid air exchange with the flute needle. ILM stuffing was done in this case after doing multiple inverted ILM flaps. ILM flaps was bridge between the gap of macular hole, thinking retinal layer will grow over it. Sometimes it can lead to RPE changes or permanent scotoma as we are touching bare RPE layer more vigorously. It is even more difficult to do ILM peel in traumatic cases with overlying epiretinal membrane. In this type of case, ILM is extremely adherent to underlying retinal layers and there are chances of microretinal tears happening during ILM peel procedure. So adherent ILM peel has to be removed very cautiously without further damaging the retina. We have also performed autologous conjunctival graft in large macular holes cases without any undue rejection of graft in a long-term basis. For this we used either use by manual method 4-port vitrectomy with or without the use of perfluorocarbon liquid PFCl as helping hands. This clip shows macular hole stuffing with a wet amniotic membrane graft, as amniotic membrane graft will work as stimuli to trigger the growth of retinal layers over the graft. After taking all safety measures, we can even finish good maculorhexis in diabetic macular edema without any complications. Now we can do internal limiting membrane peeling in detached retina even though it's quite bullous. Internal limiting membrane will come off slowly in detached retina as we are working in saline-filled eye, and light source can be used as second hand to stabilize the detached retina. We dream about to see in every ideal ILM peel. As you can see, we have used multiple pinch technique to initiate the ILM peel. Very rarely you are lucky to see this kind of ILM peel without single punctate retinal hemorrhage, which is pathognomic of ILM removal in situ. Thank you very much for patience hearing.